There are some new developments in the understanding of cervical spine pain. Old concepts regarding the segmental arrangement of innervation are changing. The relationship between chemical irritation through trauma and inflammation is clear. The involvement of posterior structures as causes of acute pain and possible relief from manipulation is more evident, and the relationship to cervical spine pain and the autonomic nervous system is becoming clearer. Let's review these new developments using the latest research. But first, let's review a few of the basic concepts regarding the innervation of the cervical spine and related structures. We'll start with the intervertebral disc, or IVD. Recall that the IVD used to be considered aneural, but more sophisticated techniques have now shown that there is innervation to the entire outer annular fibers. All afferent neurons are located in the dorsal root ganglion. The sympathetic efferent nerve cells are located in the intermediolateral cell column in the spinal cord from T1 through L2, and the parasympathetic neurons located in related cranial nerve ganglions. Dorsal root ganglion cells are generally divided into three types, which include large fibers for proprioception, medium-sized fibers for mechanoreceptors, and small fibers for pain. Sympathetic fibers in the cervical spine are found in the cervical ganglion. Parasympathetic sensory-related neurons are found primarily in the nodose ganglion of the vagus nerve. More broadly, the innervation to spinal structures is often divided into anterior and posterior. That related to the anterior spine includes the vertebra, related blood vessels, the disc, longitudinal ligament, and anterior dura, and that related to the posterior structures includes the facet joints and deep muscles and ligaments. This is further divided as follows. The posterior disc and anterior dura are supplied by the sinovertebral nerve, also known as the recurrent meningeal nerve or recurrent nerve of Luschka, which may receive components from both the local dorsal root ganglion and sympathetic components via the gray rami communicans. The lateral and anterior portions of the disc and periosteum of the vertebral body are innervated by a branch of the gray rami communicans. Because this is from the autonomic nervous system, the pain relayed is more likely felt as visceral, meaning diffuse and poorly localized. The posterior structures are innervated by the medial branch of the posterior primary rami. Innervation to each facet includes branches from segments directly above and below. We can see in this axial graphic all of these relationships, with the anastomosis of the sinovertebral nerve innervating the deeper structures, often leading to central pain, and the bilateral innervation of facet joints from the medial branch of the posterior primary rami, resulting in sided pain, meaning right versus left. Now the lateral branch. Primarily, this supply is to the more superficial muscles, such as the erector spinae and splenius capitis and cervicis, and the overlying skin. So it appears that the neurology is fairly organized and compartmentalized to segments of innervation. But let's look at some clinical violations of this simple, more segmentally focused representation. A given spinal segment of neurons within the spinal cord has been shown not to contain all the nerves that go to a specific spinal nerve. For example, the neurons in the C5 spinal segment may not contribute to the C5 spinal nerve. The result is that the nerve fibers transmitting different sensory modalities to the same area of skin may derive from different spinal segments or different spinal nerves, hence one of the explanations for different dermatomes. Clinically, this may manifest as no loss of sensory innervation if only one spinal nerve is involved. Secondly, innervation to deep structures may not be isolated to the local resident neurology at that location, but may come from distant sites. In a study by Autori et al. Published in Spine in 2001, it was found that sensory fibers of the C5 and C6 facet joints were derived from the dorsal root ganglions of C3 through T3, gaining access through the paravertebral chain. Let's review more about what is known specifically about the spinal facets. Facet joint capsules contain both low-threshold mechanoreceptors and mechanically sensitive nociceptors and silent nociceptors that can become activated if the threshold for stimulation is altered by chemical activation or irritation. It's also possible that not only the types of neurons but their function may be altered by trauma. A study by Autori et al., published in the European Spine Journal in 2002, measured the number and size of neurons that produce calcitonin gene-related peptide, compared between normal facet joints and injured facet joints. Although the percentage of these calcitonin gene-related peptide cells decreased after injury, the cross-sectional area of the cells increased, indicating a trauma-induced phenotypic switch to larger cells producing more CGRP. From previous studies, it's been established that the neurons of the dorsal root ganglion are comprised of different cell types. Using a staining technique to differentiate these, it was found that 40% of these neurons are dedicated to inflammatory pain, whereas almost as many, 32%, are dedicated to post-injury pain, contributing to prolonged pain. This distinction is based on cells that are divided into two types: small neurons that contain neuropeptides and those that do not. Those that do are nerve growth factor-dependent peptides containing neurons that are immunoreactive for substance P, an inflammatory mediator. Small non-peptide-containing neurons that bind isolectin B4 may be involved in neuropathic pain from injured tissue. The cells releasing CGRP send fibers to laminas 3 and 4 of the dorsal horn, sensitizing interneurons and other pain-related and reflex neurons. Now on to another potential cause of acute neck pain. One of the potential pain-sensitive structures that's often discussed is the synovial fold, sometimes referred to as a meniscus. This concept is not new, but has recently been revisited because of new imaging capabilities with MRI. An overview of this concept is found in the publication Synovial Folds, a Pain in the Neck by Webb et al., published in Manual Therapy in 2011. So what is this structure and what is known about its potential contribution to neck pain? Synovial folds may protect and lubricate the articular surfaces, serving also the role of filling out joint congruity and providing both stability and, with weight bearing, dissipating stress. Also, the synovium and related adipose tissues have been demonstrated to release nerve growth factors and pro-inflammatory cytokines into joints when irritated or involved in degeneration. Theories that may account for their involvement in neck pain revolve around primarily entrapment caught between articular surfaces and extrapment caught outside the articular surfaces. Entrapment is likely due to movement of the joint surfaces that pinches the synovium, entrapping some of the sensitive tissue. Synovial folds are larger and more flexible in children and likely explains why an acute torticollis is more frequently seen in children than adults, but also may explain why cervical adjusting causes immediate relief in some patients with acute neck pain. Now, let's look at the disc. In a recent study published in 2012 in Spine by Fujimoto et al., titled Sensory and Autonomic Innervation of the Cervical IVD in Rats, the Pathomechanics of Chronic Discogenic Neck Pain, the contribution to the innervation of cervical discs was evaluated for both the segmental relationship and also the percentage contribution of fibers not only from the standard sensory innervation, but also from the sympathetic and parasympathetic ganglions. New staining and labeling techniques have allowed the distinction of nerve fiber types, including autonomic nerve fibers, and even whether these are postganglionic. Studying these neural pathways, the researchers determined that some of the traditional thinking of segmental innervation, thought to be primarily somatic innervation, may be in fact oversimplified. Here are the findings from their study. The C5-C6 intervertebral disc is innervated multisegmentally. These neurons come not only from neurons providing standard pain, mechanoreceptor, and proprioceptive innervation, but also from the sympathetic nervous system with fibers from the stellate ganglion and from the parasympathetic ganglion found in the nodos. Also, the DRG innervation is from all other cervical levels of C2 through C8. Although for the cervical disc, the primary innervation is somatic sensory, with close to 80% contribution, 20% of the innervation is autonomic. Specifically, 23.9% of fibers were afferent sensory pain related, 8.9% were sympathetic efferent nerves, and 11.5% were parasympathetic efferent nerves. These efferent autonomic fibers are likely primarily involved in vasomotor effects such as constriction and dilation, but may have other effects related to sensitization of other pain fibers, reflex muscle spasm, and centralization phenomenon with chronic pain. This innervation may also explain the variety of symptoms associated with chronic discogenic pain, with this overlap of both somatosensory and autonomic innervation. It's time to summarize using 4 noteworthy concepts. Cervical facets and IVDs are innervated multisegmentally, not just from a specific segmental level. The clinical significance of that is that a source of pain at one level may spread and appear diffuse across the neck or upper trunk and also to other areas supplied by any cervical and upper thoracic segments. Innervation is not just somatic, but includes autonomic innervation that is both sympathetic and parasympathetic. The clinical significance of this finding is that signs and symptoms from autonomic involvement may be visceral in nature and create signs and symptoms beyond musculoskeletal pain. Injury can transform cells into larger producers of neuropeptides involved with both pain and inflammation. Injury promotes pain through inflammation, but also transforms cells that continue the pain cycle, prolonging the pain-generating process and therefore prolonging recovery. Synovial folds may be entrapped in facet joints, the release of which may provide immediate relief of pain. I hope that this brief overview of the new findings related to cervical pain helps explain some of the clinical presentations of your patients, and that this updating reveals a more complex neurological wiring than previously understood.